Hi everyone. In the previous video, we have seen the first stage of labor. In the second stage of labor, the main physiology that is helping for the second stage of labor. That is already we have seen the second stage of labor means it's a expulsion of the baby. The main physiology that is helping for this expulsion is uterine action. The uterine contractions will become stronger and will become longer, but in between that a regular interval will be there, and during this regular interval the fetus and the mother will get a recovery or relaxation period in between. And usually by the end of the first stage or in the beginning of the second stage, the membranes, that is amnion and chorion, will rupture and the amniotic fluid will start to leak. The continuous drainage of the amniotic fluid will be there. So what will happen means the fetal head, when it is coming down, it will come and it will get heated directly to the tissues of the cervix and vagina, and this direct pressure from the fetal part also will that is this pressure also will help for the distension or dilatation of the cervix and vagina and perineal area. And the fetal axis pressure, that is when the uterus is contracting, already we have seen in the first stage of labor, the pressure will be applying from the top and it will be applied through the long axis of the fetus and it will be applied to the fetal head, and it leads to the flexion of the fetal head. That is when the pressure is getting applied, again the fetal head will get flexed and the smallest diameter will be presenting, and it helps for the rapid progress of the labor, and at the same time this smallest diameter helps for preventing the trauma for the baby and for the fetus, because if largest diameter is passing through the birth canal, when it is passing through the pelvis, there is a chance for compression of the fetal head. And if largest diameter is passing through the birth canal, when it is coming out, there is a chance for tear, that is there is a chance for perineal tear, cervical tear. So all those things can be reduced when the smallest presenting diameter is present. And the uterine contractions will become more expulsive when the fetus is descending downwards into the vagina, and when it is touching the vagina, it will stimulate the nerve receptors of the pelvic floor, and this stimulation, when the nerve receptors of the pelvic floor is getting stimulated, the lady will get a tendency to push the baby down, and this reflex is known as Ferguson's reflex. And the mother also will apply, because of this reflex, the mother also will use her secondary muscles and accessory muscles to push the baby down, and the uterus also will be contracting severely, or expulsive contractions of the uterus also will be there. All these things will help for the expulsion of the baby. That is, the mother will be using pressure by contracting the abdominal muscles, diaphragm and all the accessory muscles, and the uterus also will be contracting. All these forces together will help for the expulsion of the baby out of the uterus. And another thing which is happening during the second stage is replacement of the soft tissues. When the fetal head is coming downwards, that is when it is descending downwards, the soft tissues of the pelvis will get displaced. It will move, or it will get displaced sideways. The bladder will move anteriorly, and posteriorly the rectum will move, and the levator ani muscles will move sideways, and the perineal body also will get displaced, and this helps for the descent of the baby, or for the downward movement of the baby. And when the fetal head, when it is visible at the vulva, and again it will be coming down with each contractions, the fetal head will be coming down, and again it will recede backward uh, when the contraction fades or when the contraction stops. This process will be continuing till the crowning. I will be explaining you what is crowning, that I will explain later. Anyway, this uh, extension of the head or the descent of the head, and again it is going back or receding back, this process will be continuing till the crowning. After that, the head will come out, or the delivery of the head will occur. After the delivery of the head, the shoulder and the body also will deliver along with the next contractions, or along with the subsequent contractions. And along with the delivery of the shoulder and body, balance amniotic fluid or the gush of amniotic fluid, and sometimes even mild amount of blood due to the separation of the placenta, that also will come out of the uterus. And that is the second stage of labor. Now we can see the presumptive signs of second stage of labor. How can you identify whether the woman is in the second stage? One is expulsive uterine contractions will be there, and the rupture of membranes or rupture of aorta will be there. And if you are observing the perineal area, you can see the dilatation and gapping of the anus, and appearance of rhomboid of Michaels will be there. Rhomboid of Michaels means it's a kite-shaped area that includes a three lower lumbar vertebra, the sacrum, and the long ligaments. These three things will form a kite-shaped area. This area will become more prominent when the baby is descending into the pelvis, because it helps when the baby is coming down, this area will get projected outward, and it will the examiner or the nurse or doctor will be able to see that triangular area, differentiate that triangular area. And next one is show. Show already I have explained in the first stage of labor. This show sometimes it may occur in the first stage itself, but sometimes it may be coming in the beginning of the second stage. And another one is appearance of the presenting part. If you are observing the vulval area, you will be able to see the presenting part. And if you are doing the pervaginal examination, you can see the 10 centimeter dilatation of the cervix. Already I have told you that the second stage of labor is from the 10 centimeter dilatation to the of the cervix to the expulsion of the baby. For the details related to the duration and time duration, see the previous video about the first stage of labor. So anyway, these are the presumptive signs of second stage of labor. If these signs are there, means you should suspect, or you can make sure that the second stage of labor has started, and you should make arrangements for receiving the baby. Next, we can see the mechanism of labor. This mechanism, one more video demonstration is there, that also you can see after going through this theory. Always when you are telling the mechanism, you should tell the lie already it is explained. It refers to the relationship of the long axis of the fetus to the long axis of the maternal spine. So in the usual case, the lie will be longitudinal, and even oblique transverse lies are also there. This is longitudinal lie and this is transverse lie. Next is presentation. Presentation means it's a part of the fetus which present in the lower pole of the uterus. Here see, head is there, here face is there, here occiput is there, here buttocks is there, here shoulder is there. These are the different presentations that you can see commonly. Next is the presenting part. It is defined as the part of the presentation which overlies the internal os of the cervix and can be felt by the examiner through the fingers. That is the part of the presentation which is lying over the internal os of the cervix. And if you are doing the vaginal examination, you will be able to feel this presenting part. Where you are feeling, that is the presenting part. Next is attitude. It is a relationship of the different parts of the fetus to one another, and the universal attitude is flexion. Already I have told you. See, this is the universal attitude. The baby is completely flexed. The extremities are flexed towards the abdomen. See, hands are flexed, limbs are also, lower limbs are also flexed, and the head is flexed towards the chest. This is extended, this is slightly deflexed, this is fully deflexed. This is the normal position, complete flexion. And next is denominator. It's an arbitrary bony fixed point on the presenting part which comes in relation with the various quadrants of the maternal pelvis. This also we have seen already in the positions of the baby. In case if you want to have explanations related to that, you just see the previous video about the position of the baby. And the following denominators of the different are the following are the denominators of the different presentations. That is, in the case of vertex presentation, occiput is the denominator, and in the case of face presentation, denominator is mentum, and in the case of brow presentation, the denominator is frontal eminence, and in the case of breech presentation, the denominator is sacrum, and in the case of shoulder presentation, the denominator is acromion process of the shoulder. Just by heart all these denominators. Next, the position. Depending on where this denominator is there, on the basis of that we can divide the position. If the denominator is pointing towards the symphysis pubis, the position is occipito anterior or direct occipito anterior. If the denominator is pointing towards the right iliopectineal eminence, the position is right occipital anterior ROA. If the denominator is pointing towards the midline of the iliopectineal line, that is known as over the right side, it is known as right occipital transverse. And if the denominator is pointing towards the right sacroiliac joint, the position is right occipital posterior. And if the denominator is pointing towards the, that is here, whatever I have told, the denominator is occiput. That is, if the occiput is pointing, that is, here I'm telling about the vertex presentation. That is a normal presentation actually. And if the occiput is pointing towards the sacrum, directly towards the sacrum, it is direct occipital posterior. And if the occiput is pointing towards the left sacroiliac joint, the position is left occipital posterior. If the occiput is pointing towards the left middle line of the iliopectineal line, that is known as the position is left occipital transverse. And if the occiput points towards the left iliopectineal eminence, the position is left occipital anterior or LOA. These are the different positions you can expect in the case of vertex presentation. Next, we can see the mechanism of labor. The mechanism of labor is, as the fetus descends, the soft tissues and bony structures exert pressure which force it to negotiate the birth canal through a series of passive movements, and these movements are collectively known as the mechanism of labor. That is, when the baby is coming downward or when the baby is descending downwards through the birth canal, a series of movements are occurring for the baby, and that movements are collectively known as the mechanism of labor. And there are three principles for all the mechanism. Descent takes place throughout the labor. Whichever part comes and meets the resistance of the pelvic floor will rotate forward until it comes under the symphysis pubis. These explanations I am not giving over here. The demonstration of these principles are given in the video mechanism of right occipital anterior position, ROE. That you please see that video along with this. Whatever emerges from the pelvis will pivot around the pubic bone. These are the three principles. Always when the students are telling the mechanism, first they should tell the definition of mechanism, then they are supposed to tell these three principles also. Next, they should tell the 6 considerations of normal labor. That is, they should tell what is the lie. In the normal case, the lie is longitudinal. The presentation will be cephalic. Position is right or left occipital anterior. Attitude is one of good flexion. Denominator is occiput, and the presenting part is posterior part of the anterior parietal bone. So this is the considerations for the normal labor actually. So this also we should tell when we are telling the, or when we are explaining the mechanism of labor. The cardinal movements or the main movements in the normal mechanism are engagement, descent, flexion, internal rotation of the head, crowning of the head, then extension of the head, external rotation, restitution, internal rotation of the shoulders, same time external rotation of the head will occur, and lateral flexion. Actually here it is not full external rotation, it is just slight rotation only, and we are calling it as restitution. Now let us see these movements one by one. Here actually the head is not engaged, head has not entered into the pelvis, that is, it is not engaged. First one is engagement. Engagement is the mechanism where the biparietal diameter or the greatest transverse diameter in the occiput presentation is passing through the inlet of the pelvis. So if the widest transverse diameter has entered into the pelvis, then we can tell that it has engaged. Next is descent. Actually, this is the downward movement that is occurring throughout the labor. So the descent takes place throughout the labor, and it will be different in nulliparous and in multigravida mothers. That is, in the case of nulliparous or in the case of primi, it will be slow, and in the multigravida mothers, less resistance of the pelvic floor tissues will be there. So the descent or downward movement will be more faster. And throughout the first stage of labor, the contraction and retraction of the uterine muscles allow less the size of because of the contraction and retraction of the uterine muscles, the space inside the uterine cavity will decrease, and pressure inside the uterine cavity will be increasing, and this less space and increased pressure in the uterine cavity will push the baby downward. And at the same time, already I have told you that the upper segment of the uterus will be contracting, and it will act as like a piston, and it will push the baby downward. And after the rupture of the membranes, actually following the rupture of the forewater, the exertion of the maternal effort progress the speed up. That is, when the membranes are rupturing, already I have told you that the fragusence, reflex, all those things will occur. So the maternal effort also will increase, and the mother also will start to push the baby downward by using her abdominal muscles, diaphragm, and her accessory muscles. This also will speed up the process of labor, especially in the second stage. So now the biparietal diameter has entered into the pelvis, that is engaged, and descent also has, that is down, it is coming downward also. Next movement is flexion. So when the head is coming downward, we know that down pelvic floor tissues are there, muscles of the pelvic floor is there, cervix is there. So this head will be meeting the resistance from this pelvic floor. So when it is meeting the resistance, what will happen means the head will flex, or it will get flexed. So due to the flexion, what will happen means the suboccipito-frontal diameter 10 centimeter will become suboccipito-brecmatic 9.5 centimeter, and the occiput will become the leading part. So this flexion helps for reduction in the presenting diameter, and it allows the easier passage of the baby. Next is internal rotation of the head. So in the ROA and LOA, here we are discussing about that only. When the occiput is meeting the resistance of the pelvic floor, because of the angle of inclination and due to the contractions, this occiput will rotate forward towards the symphysis pubis until it is coming under the symphysis pubis. It is the second principle. In the principles of labor, we have seen that the second principle is whichever part meets the resistance of the pelvic floor will rotate forward until it comes under the symphysis pubis. So here the occiput is meeting the resistance of the pelvic floor. So this will rotate forward and it will come under the symphysis pubis. And in the right occipito-anterior position and in the left occipito-anterior position, already I have told you that the occiput will be over the iliopectineal eminence. So it is needed to travel, or it is needed to get rotated only 1/8 of the circle. So if this will rotate 1/8 of the circle, and it will come under the symphysis pubis. So when it is getting rotated, actually there will be a slight twist, that is the head alone is getting rotated, so there will be a twist for the neck. Next, what will happen means after this internal rotation, the head will come into the anterior posterior diameter of the pelvis. So the occiput will come under the symphysis pubis or subpubic arch, and the sinciput, that is face, will be towards the sacrum, and later the crowning will occur, and the flexion will be maintaining, and the suboccipito-brecmatic diameter will be coming downward. So that will be the diameter which is passing, or which is distenting the vaginal orifice also later also. That is full descent and internal rotation. The picture, see here, this actually it was the position, and now it will rotate and it will come into the anterior posterior diameter of the pelvis. So the sagittal suture of the fetal skull will be in the anterior posterior diameter of the pelvis. See here, it has rotated completely from the previous picture. In the previous picture, you might have observed that this sagittal suture was in the oblique diameter. Here, this has rotated, this circle, 1/8 circle, and it come under the symphysis pubis. Now it is under the symphysis pubis. Next is crowning. What is crowning means? After the crowning, the head will not recede backward. So after the crowning, what will happen means extension of the head will occur. So due to the extension, the sinciput, face and chin, that is mentum, will sweep the perineum and will be borne by a movement of extension. Now the head has delivered fully. See, the inciput phase and momentum is sweeping by the extension. Next is restitution. Already I have told you that during the internal rotation, there will be a slight twist in the neck. So this twisting movement will get corrected. That is an untwisting movement of the head. So the twist of the neck will get corrected. So that is known as the restitution. So this is occurring in the opposite direction of the internal rotation. So here you can see the restitution. Now the head and body is in the same alignment. There is no twist for the neck after the restitution. Next is internal rotation of the shoulder. So here also, after the delivery of the head, now the shoulder will come to the pelvic floor and the shoulder will start to meet the resistance of the pelvic floor. So this also will rotate. So the shoulder will be entering in the same oblique diameter. So this will rotate 1/8 of the circle, and this also will come under the symphysis pubis. So now the shoulder, that is from the oblique diameter, the shoulder will come to the anterior posterior diameter of the pelvis. So after the internal rotation of the shoulder will be in the biacromial diameter will be in the anterior posterior diameter of the pelvis. Next is lateral flexion. After the internal rotation, actually along with the internal rotation, external rotation of the head also will occur. The head also will rotate externally. So now again the head and body will come to the same alignment. After the external rotation, what will happen means the shoulder will slip beneath the subpubic arch and the posterior shoulder passes over the perineum. After the delivery of the shoulder, the rest of the body is borne by lateral flexion as the spine bends sideways through the curved birth canal. So the body will be delivering towards the mother's abdomen by a movement of lateral flexion. See, here you can see the delivery of the shoulder. This is the movement for the delivery of the anterior shoulder. This is the movement which is helping for the delivery of the posterior shoulder. And now the complete delivery or the second stage has completed by the delivery of the baby. Once again, for the mechanism, I'm just requesting you to see the demonstration of the mechanism of labor. Next, we can go to the third stage of labor. The third stage of labor is the separation of the placenta, membranes, and its expulsion also. The third stage of labor begins immediately after the delivery of the baby, and it includes the separation of the placenta, descent of the placenta, expulsion of the placenta and membranes, and stoppage of bleeding or control of hemorrhage after the delivery of the placenta from the placental site. And the total duration, the maximum duration is 30 minutes, and usually it will get completed within 5 to 15 minutes. Now we can see the factors which are helping for the separation and delivery of the placenta. The mechanical factors include, as the fetus is born, the uterus will contract severely for reducing its contents. So when the uterus is contracting, the fundus of the uterus is contracting and it will come below the level of the umbilicus. So when the uterine fundus is contracting, the placental site will get diminished. The placental area, the site where the placenta is getting attached, that area is getting contracted. So that size of that area will reduce. So when the size of that area is reducing, what will happen to the placenta? Naturally, the placenta which is attached over there will start to get separated, and the blood vessels which are supplying to the placenta will get compressed, and the blood will get squeezed into the intervillous space. That is, it will come into the spongy layer of the decidua basalis. So here this portion of the placenta will be contracting, uterus will be contracting. So when this uterus is contracting, the blood vessels of this area also will get squeezed, and the blood vessels will of this area will get squeezed, and the blood will enter into this space, and the blood which is entering over this space, this will form a clot, and this clot, its weight will help for the, when something is there with weight, it will help for the downward movement, or again due to gravity it helps for the further separation of the placenta, and the placenta will get separated. Along with that, peeling of the membrane also will occur, and it will come out of the uterus. So this is the thing which is occurring in the placental separation. So now we can see about the other mechanical factors. The retraction of the oblique uterine muscle fibers exert pressure on the blood vessels. So what will happen? The blood which is collected over that area, already I have shown you in the picture, the blood will be collecting in that space. So this will not get back into or go back into the maternal system, maternal blood vessels or maternal system, because the blood vessels of the maternal side also will get contracted. So the blood will be stagnating over there and it will get a clot formation, and it helps for the further separation and stripping of the placenta, that already we have seen. As the surface area of the placenta attachment reduces, the relatively non-elastic placenta begins to detach from the uterine wall, and this retroplacental clot also will help for the detachment, already I have told you. Next we can see the methods of placental separation. That first one is Schulet's method. That is, the placenta usually separates from the center. So this Schulet's method is otherwise known as the centralized separation of the placenta. See, already in the previous picture, I have explained a retroplacental clot or blood will be getting collected in between the placenta and the endometrium. So because of the weight, it helps for the further stripping of the placenta and membranes, and peeling of the placenta and membranes will occur, and this will get this membranes, placenta, everything will descend downwards and it will come out of the uterus. This type of placental separation is the common separation, and it helps for the complete separation of the, or it is associated with the complete sharing of the placenta membranes and with less fluid loss. And another one is Matthew Duncan's method or marginal separation. So here the placenta will be getting separated, or it will start to separate from the borders. That is why it's known as the lateral separation or marginal separation. So the blood which is coming out of this placenta will be escaping through the sides of the placenta, and it will not form the retroplacental clot, and this clot will not be helping for the further separation of the placenta. And when it is getting shared, it will slip sideways, and gradually it will be coming out, and usually the maternal surface of the placenta will be coming out first. But in the case of Schulet's method, the fetal surface of the placenta will be coming out first. But this Matthew Duncan process will take long time, and again the blood loss also will be more, and sometimes few membranes or remnants of membranes may remain inside the uterus itself. There is a chance for that also. So this picture shows the Matthew Duncan's methods and Schulet's method. Schulet's method, see, centralized placenta is there and it is coming out. So the fetal surface of the placenta is coming out first. But here in the Matthew Duncan's method, laterally it is getting separated. So it is getting shared and the maternal surface is coming out first. Next we can see the separation of the fetal membranes. The uterine activity, that is the contraction of the uterus, will decrease the surface area of the uterus, and because of this decreased surface area, the fetal membranes will start to separate. That is, a chorion and amnion will start to separate, or it will form a lot of folds, and it will, because of the separation, and the membranes will remain there itself until the separation of the placenta is getting completed. And when the placenta is getting separated and when it is coming out, the fetal membranes also will get peeled off from the uterine wall, and partly by the further contraction of the myometrium and partly by the traction which is exerted by the separated placenta, the fetal membranes will come out of the uterus through the vagina. So the two factors which are helping for the separation of the fetal membranes are, one is uterine contraction and another one is traction by the placenta also. Next is hemostasis. Actually, immediately after the separation of the placenta, the oblique muscles of the uterus, the uterine myometrium, will start to contract, and this will act as like a ligature, and it will tie it, that is, it will act as like a tie around the blood vessels, and it helps for stoppage of bleeding in the postnatal period or in the immediately after the delivery. See, these are the oblique muscles, and these sutra things are the blood vessels. So during the time of placental separation, these blood vessels will get cut off. So what will happen means, immediately these living ligatures or this oblique muscles will get contracted. So here it is getting contracted. You see, it will come together. So this will produce the contraction of the, it will compress the blood vessels and it exert pressure on the blood vessels, and it will act as like a clamp or ligature, and it helps for the prevention of bleeding after the delivery of the placenta. So this vigorous uterine contractions following the separation brings the walls into opposition, so the further pressure is exerted on the placental side. There is a transitory activation of the coagulation of fibrinolytic system during and immediately following the placental separation. See, in the physiological changes during pregnancy, I had told you that during the pregnancy, the clotting factors in the body will be high. So this high amount of clotting factors and platelet count in the body will help for the clot formation immediately after the delivery. So this also will help for the stoppage of bleeding. So the two factors which are helping for the stoppage of bleeding after the delivery of the placenta are, one is the oblique muscles of the uterus will be acting as like ligatures over the blood vessels, and it helps for the contraction and it stops the bleeding. And second thing, the fibrinolytic systems of the body, that is already I have told you that the clotting factors amount in the body will be high. So immediately after the separation of the placenta, clot will get formed over the placental site, and that also will help for the stoppage of bleeding. So these are the main events which are happening in the second and third stage of labor. In the next video, that's a continuation of this video, in that we will be discussing about the signs of placental separation and the fourth stage of labor. So thank you for watching this video, and see you soon with the next video.